So again, I'm Dr. Stacy Gordon. I'm a social worker, a gerontologist, a former geriatric care manager, and currently the program director of Next Phase Adult Caregiving and Retirement at NYU WorkLife, and the director of the brand new NYU Society of Retired Faculty. My own research is in the area of ageism, particularly ageism in the family, and how families unwittingly reproduce negative age attitudes that are partly a result of gaps in the systems of care for older people. More on that in my presentation tomorrow. In my line of work, I've been an advocate for older people, and I've worked with physicians, geriatricians, and others less familiar with the common and uncommon issues of old age, and other allied health professionals like nurses, physical therapists, occupational therapists, and speech pathologists. And what strikes me about Dr. Aronson's writing is not only her beautiful prose, but after my own work with families and their older loved ones for many years, what strikes me is how universal her stories are, and how through her storytelling, it is clear that she, in her very special way, provides care like a doctor, treats like a social worker, writes like an historian, analyzes like a policy wonk, and interprets like a literary critic. She sits at the intersection of all of these fields and presents a consistent, fresh, and out-of-the-box message of reimagining systems of care, making time and space to have difficult and complicated conversations about illness and death, treating older people like the grown-ups they are, and showing respect for the humanity and personhood of older people, reframing our view of what the oldest old can do, demanding that we transform the systems that not only do not hold up to the litmus test of actually helping older people live meaningful lives. Dr. Aronson is a visionary and a leading geriatrician who, from her perch at UC San Francisco Medical Center, teaches, practices, and writes. She presents a radical vision in her call to redefine aging. And she's the person on whose side you want to be as you grow older. She's shaping public discourse through her many written pieces in the New York Times, the Washington Post, JAMA, the New England Journal of Medicine, Harvard Medicine Magazine, and news media features, such as on NPR's Fresh Air and Morning Edition, Politico, and The New Yorker. At the University of California, San Francisco, Dr. Aronson has served as founding director of Care at Home and the Optimizing Aging Project. She served as the director of the Pathways to Discovery program and Northern California Geriatrics Education Center, as well as chief of geriatrics education. In addition to her clinical practice and teaching, she currently leads the Age Self-Care program and UCSF Medical Humanities. In 2020, Dr. Aronson was the clinical lead for the senior hub of the San Francisco Department of Public Health COVID-19 response and served on the California State COVID vaccine allocation work group. She continues to serve as an advisor to the state of California on COVID-19 in elders and elder care settings. Dr. Aronson has received the Gold Professorship in Humanism in Medicine, the California Home Care Physician of the Year Award, and the American Geriatric Society Clinician Teacher of the Year Award. In her 2019 Pulitzer Prize nominated book, Elderhood, Redefining Aging, Transforming Medicine, and Reimagining Life, Dr. Aronson reflects that life offers just two possibilities: die young or grow old. And her colleague, Dr. Lucy Kalanithi, comments that this searing, luminous book is for everyone who hopes to accomplish the latter and remain fully human as they do. Further, she says that this book will challenge your assumptions and open your mind, and it just might change your life. So with that, please help me welcome Dr. Louise Aronson.
Thank you. That was, so I will say I've had a lot of introductions, and that was pretty clearly the best one ever. That part about that the care I provide is that of a social worker is clearly the highest compliment I've ever received as a clinician, and actually has been my secret ambition. Doctors will sometimes use that as an insult. I had a recent trainee who was applying to medical school to go into geriatrics and gerontology, and everybody kept saying to her, "Why don't you want to become a social worker?" As if our social lives and human selves aren't an essential part of our health. Anyway, thank you for that incredible introduction. I should probably start my presentation. So I will do that. And here we go. If only I could see it myself. Okay. So I'm going to talk about redefining aging, transforming medicine, and reimagining life, but I'm going to do it a little bit through the lens of the last year and a half or so that we have all survived thus far. I want to start by showing how what happened with COVID really points out some key lessons about aging and ageism that make a difference in everything we do and think about, really. Then consider how the ways we talk about and approach old age actually can make it harder. And then finally, identify some steps we can all take as individuals and as a society to make aging and elderhood better for all of us. So one of the poignant things about COVID was how it preferentially affected older people, and also how the curve of deaths really kind of showed us where middle age falls, sort of in that 45 to 65 age range. And that old age has different subgroups, right? So when we think about children, we often, universally across cultures, you will get neonate, infant, toddler, child, tween, teen, young adult. There is this predictable pattern. Adulthood and elderhood are a little different. And yet each decade does bring changes. Some of us who are more fortunate might be in our 50s as others are in their 40s. I did consults at one point in San Quentin, and people who were newly incarcerated for the first time in their lives in their 60s would be sort of middle-aged people, and people who'd been in and out of the system or had grave mental illness were sort of 62 going on 85. So yes, who we are and where we live matters, but there is something about age itself. And indeed, this curve is a lot like the curve for death, because of course, death eventually gets to 100% of us. And for the more fortunate among us will die as we're very old. And yet, clearly COVID showed that age matters. But it also showed that age isn't everything. So this is work from the incredible Mary Bassett at Harvard, showing racial and ethnic disparities in deaths in people ages 75 to 84, right? So this is a high-risk group. That's what we usually hear about. And we've also heard about how Black and brown people have had more COVID than had disproportional amounts of COVID. But we haven't always seen is this, that among people in their late 70s and early 80s, the rate difference in risk for death from COVID was nearly 900 for Blacks, over 500 for Latinx, 200 for Native Americans, and 150 for Asian and Pacific Islanders. There was a lot of speculation about that. Let me be clear that there's no biological reason why this should be. This is a failure of our systems of care, both social and medical. There was an interesting article this summer in JAMA, one of the leading medical journals, which looked at why this might be, why there might be such differences in just Medicare beneficiaries. And what they found was the reason that Black and brown people died more often was because they went to bad hospitals where your outcome was worse if you had a regular pneumonia, if you had a heart attack, if you had a broken leg, if you needed your appendix out. So this really just emphasized the structural differences that have been present since our founding as a nation. Frailty matters. Now I'm going to speak a bit about nursing homes, not because most older people live in nursing homes, about 4% of people do, with another percent in assisted living and other senior care communities, but because it's kind of the quintessential old age situation, right? It's the oldest people, it's the frailest people, it's the people, put together into a place because society doesn't know what else to do with them. The first outbreak in the US was in a nursing home. By May of 2020, as you can see on the right, in half the states, or in 18 states, at least half of the deaths were in nursing homes. And by March of this year, it turned out about 1 in 10 people in nursing homes were dead. Now, this was before newer evidence that we'll come to, which actually counted the lives that the federal government literally didn't count. They said facilities did not have to count anyone who died before the middle of May 2020, so literally not counting certain lives. But frailty matters. You know, people didn't just die, they were more likely to die if they were very old, 80s or beyond, and if they were frail. But policies and priorities were what shaped this conversation as they did for Black and Brown Americans. PPE shortages continue to this day. We had facilities, particularly assisted living facilities, which were never prioritized, where the executive directors were calling people to ask for help with getting masks and basic PPE. They were not prioritized. Meanwhile, people on sports teams had plenty of PPE. People in Hollywood had plenty of PPE. Silicon Valley had stockpiles of PPE. But nursing homes, even after we knew it was a huge percentage of deaths, were not given the PPE they needed. Testing, this was 7 months in federal effort to expand COVID-19 testing, hit snags. The key to not having an outbreak is having enough PPE and having the ability to test so that you can jump in and isolate people as soon as they're infected. But these people were not prioritized. And then even the vaccine effort, which was transformational, sort of miraculous, got off to a much slower start and didn't finish until 4 months after CVS and Walgreens thought it would be finished, because they didn't know anything about nursing homes, and the people who gave the contracts to CVS and Walgreens didn't realize that there were pharmacies that already dealt with nursing homes, because they themselves, making policy for nursing homes, knew so little about those facilities. Meanwhile, you might have noticed that in speaking about the vast majority of older adults who were not in such facilities, there was almost total radio silence. Even though we saw all the ways age matters, this is showing rates of hospitalization and death and how they start going up significantly in middle age, get worse once you're in your 60s, worse still in your 70s, and even more so in your 80s, because age does matter. People who don't see age are like people who don't see race. They are not actually seeing the individual before them and the factors that shape their unique reality. And yet age isn't a single category, right? We did see these step-ups by age group, and we also saw differences by gender. In the United States, this is data from Spain, where it was more so, again, showing how biology actually might be part of the difference between men and women, but it also may be a pattern of behavior, which is well documented in males. We train them to be stoic, and then we blame them for being stoic and not showing up to the doctor or hospital in time. So that too isn't a cultural issue, but beyond the scope of this talk. There's so many ways to show the ways age poses risks, but I also wanted to show the way in which age offered opportunities in this time, with some of our key government leaders all being in elderhood themselves. I want to go back. I should add that obviously they share a key demographic trait, which speaks again to our inequalities. So for some people, old age offers more opportunity than for others. Thinking about aging, medicine, and life, it's important to think about ageism for reasons I hope will become more and more obvious, although you're probably already convinced just by life itself. But Bob Butler was the one who coined the term. He was the first director of the National Institutes on Aging, started the first geriatrics department in the United States in the 70s, and he talked about ageism as a process of systematic stereotyping or discrimination discrimination against people because they are old, just as racism and sexism accomplish with skin color and gender. Ageism allows younger generations to see old people as different than themselves, thus they subtly cease to identify with their elders as human beings. Since this definition, we have expanded ageism to allow for any sort of age discrimination against young people, against middle-aged people. And yet it's probably true, I think we could make a very strong case that the greatest amount of ageism falls on the old. We saw this in pandemic. This was a headline from Time magazine, "The Road to Recovery, How Targeted Lockdowns for Seniors Can Help the U.S. Reopen." Interesting that the initials for our country also spell the word us. So there is us and there are seniors. And we will lock up people who have not committed a crime without judicial review for the good of us, those of us who are not young. This is a person on Twitter who starts her diatribe with, "You can call me a grandma killer," an irony that speaks to something quite common, which is we cannot imagine our older selves when we are young. So this woman is pictured with one of her children. She is what my colleague Joanne Lynn would call a grandmother in training. And then the ethicist Peter Singer, some of you may have seen a New Yorker profile of him this summer, or the fact that he won a major international award for his ethics, argued in an international publication that probably it was. Here's my curbside ethics. I think maybe if you're on a sinking boat in the middle of nowhere and there's a 12-year-old and an 82-year-old and you can only help one, you pick the 12-year-old. I would argue that in one of the richest countries in the planet, we are not in a sinking ship. The analogy does not hold. Bob Butler had some sort of sub-points to his definition of ageism. One was prejudicial attitudes towards older people, old age, and the aging process. The fact that testing wasn't given to the people who were most dying. The fact that my state governor in California wanted to cut all home care services. So his logic was, well, people shouldn't have any contact with old people because we could make them sick and kill them. So we'll just stop paying for home care and we can divert that money to the COVID crisis, not realizing that people don't just get home care to, take dancing lessons. It's really about enabling them to age in place, and that if you cut those services, they would have been forced into the nursing homes that were already becoming slaughterhouses. Luckily, we made a lot of noise and this did not happen, but sort of showing the many levels at which people don't understand the situations of old age in a way they tend to understand about childhood and adulthood. And then I mentioned this earlier, that the federal government gave nursing homes a buy on the people who had died in the first few months of the pandemic, as if those lives just didn't really matter. And the convenience of institutions was greater. This was also something I mentioned. This was in an assisted living facility having a big outbreak where a nursing assistant whispered to me in Spanish, we're wearing these same outfits all day long, going from sick people to healthy people. When confronted about this, the executive director said he couldn't get PPE anywhere. He had sent emails to everyone he'd ever met, asking them to go to Costco or Walgreens or anywhere else and send him anything they could get, and he would pay them. That's how bad it was. Bob Butler's second point, discriminatory practices against older people are typical of ageism. So consider the public-facing website of the Center for Disease Control during the pandemic. This was the site that was up through April of this year. So for over a year, this was how people got their information. You can see the different sorts of things a person might want to know. And then they actually call out age. They call out age with a subcategory for children and teens. You'll see there's a plus there, and that leads to a 9-item pull-out menu, which is important because even though children and teens tend not to get sick very often, and that is a wonderful thing compared to the 1918 pandemic, their adverse consequences from the lockdown itself and the changes in society have been significant, and some kids do get sick. But if you're going to call out age, it's very interesting that you wouldn't call out the group with 80%, that account for 80% of the mortality, even though they're only 17% of the population. And yet that's exactly what happened. For a long time, you had to click the little plus next to people at increased risk, and then you got a single page. Subsequently, in last April, they added more pages, but again, they didn't have the same understanding of old age that they had of children and adults. So you get nursing homes as one thing, no mention of assisted living. You get caregivers for people with dementia. You get adult day services, but you don't really get older adults with a parallel process as you got for children and adults. Similarly, although this was the population most affected, they were underrepresented, vastly underrepresented in vaccine and treatment trials. Now, I will say on a positive, they were better represented than they would have been just a few years ago, and I will tell you why later in the talk. Stay tuned for that happy news. Bob Butler's third point, institutional practices and policies that perpetuate stereotypes about elderly people. So this was an article in New York Magazine early on in the pandemic, July of 2020. And this writer sort of went over our history of ageism in America, but particularly for COVID, said of the governors of New York and New Jersey that they had calculated the risks in front of them, and as hospital beds ran low, shifted the burden to those least able to shoulder it, forcing the sick into nursing homes. So these were basically community dwelling people who got COVID in New York and New Jersey when everybody of all ages was getting COVID. They recover a little more slowly, couldn't go home and take care of themselves the way some younger people might be able to, because you bounce back a little more slowly as you get older. So they sent these people with COVID into nursing homes, the same nursing homes that didn't have the ability to test, that hadn't received public health support to know how to quarantine or isolate cases or suspected cases, the same nursing homes without PPE. And that is part of what caused the huge case rates in nursing homes. It is also part of what caused the hugely disproportionate risk to poor people and people of color, who are the people earning a not living wage, at least in my part of the world, for doing this work that is so hard that families outsource it. Indeed, if we look at the key elements of pandemic response, we will see that older adults, those at highest risk by far, were prioritized for one area only, vaccination. And even that had its faults, as I mentioned earlier. So better than nothing, but my gosh, can you imagine this being done if it was any other demographic group? I think it's inconceivable, although maybe if it was Black or brown people who also happen to be poor, pretty appalling performance by our country. There's some other really good information on ageism from the Ontario, Canada Human Rights Commission. They talk about a tendency to structure society based on an assumption that everyone is young, thereby failing to respond appropriately to the real needs of older persons. I actually have been on call this last week and saw this play out this weekend in the emergency department, where the fellow on call and I sent an 89-year-old who was having a gout flare in her knee. So gout leads to a swollen red, extremely painful joint, and she was having trouble walking and taking care of herself, although normally she is entirely independent. So she got in there, and one of the great things about gout is you can pull off some fluid, you can inject some steroid, the person feels better so quickly. But it turns out there's a policy that says that you can't do that, because that's considered sort of an outpatient thing, like it can't be emergent, right? Well, in a younger person, it's not emergent. You hand them maybe some crutches, and you can give them pills like ibuprofen type pills, which help a lot, which they can safely take. But in an older person, that can hurt your kidneys. It can make you bleed. You don't want to take it if you don't have to. So here's this woman. She can't take the medicines that are going to be most helpful. There's a very simple procedure that takes a matter of minutes, worst case scenario if you have trouble, maybe 10 or 15, but in a swollen knee, it's quite easy. And they literally won't do it because there's a policy that it's like It's like an extra. It's a bonus. It's not an emergency thing. But for her, it was an emergency because without that injection, she had to go to a nursing home. So that's just one recent example of the sort of small ways in which people don't think about old age as a separate category with unique needs and demands. We saw this also in COVID. I have put a few references down here, but there are tons and tons and tons of them. This was a study from an emergency room, which said about 3 in every 10 people were confused at presentation. That was their sole presenting symptom. And about 4 out of every 10 had no classic COVID symptoms. Now, I learned this in early March from physicians in Italy who were already seeing this. At no time has it appeared on the CDC website or on local or state websites, despite a huge literature about older adults and frail older adults. At UCSF, once again, the top medical center west of the Mississippi, we had adult and pediatric algorithms. We had pediatric algorithms before we had anything else. We very briefly had an outpatient elder algorithm, but for the most part, this entire literature was ignored, despite the fact that we claim to provide evidence-based medicine. This is really structural ageism. The harms, harms in the age of harm reduction. Part of how we learned to respond to COVID and the parts that went well came from AIDS, which is actually part of what made me a geriatrician, ironically, because it was where I learned about advanced illness and how to help people die well in the early 90s. But what happened in many places was they said no visitors. This includes in nursing homes and assisted living facilities. But they were accepting certain kinds of visitors. If you were a child and needed your parent, that could happen. If you were in labor and wanted your partner, that could happen. If you were dying and needed your family, that could happen. But the sort of people who really get into trouble and in fact get drugged and tied down when they're sick, people with dementia, which is a huge percentage of older people, not the majority, but a lot of people, and anyone who develops delirium, as we saw at least a third of people did, and in older age groups, it's up to 70% of people develop delirium, in other words, confusion. That is when family can keep you from getting more drugged in a way that might make it impossible for you to eat, that might lead to bed sores, all these things. So people were left basically, and the visitors would come and help people eat. So whether you're a healthy or a not so healthy older person, having someone there to help you in the hospital is essential to good outcomes. That is well established, and yet older people were not on the list once again. There's also been the social distancing crisis. I saw another patient this morning, actually just in her late 60s, who is clearly suffering from this herself. And then the excess mortality, the people who were so scared of the risk to older people that they didn't go to the hospital with their heart attacks, their strokes, they didn't follow up on their cancers, on other new symptoms. That disproportionately affected people in their 70s and 60s and 80s and beyond. When we did prioritize older adults, look what happened. Death rate plummeted, right? And all US cases were coming down a little, but not to the same degree. When we prioritized older adults, they remained alive. So this wasn't just about the differences of old age. This was about a failure to prioritize those at highest risk. And you can see here how people age 75 plus in the community, as they got vaccinated, the risk went up for the next highest group, those in middle age, where we also saw we were at higher risk. Okay. Huge preamble, but just to show how these things play out and how they play out so regularly in our world. COVID was just like a lens on all these things we already know. How we talk about old age really makes a difference. We often tell stories like eat your kale and blueberries, you don't have to grow old. These are super helpful for good health, for trying to have our health span, the years in which we're healthy, be really close to our lifespan, the years in which we live, instead of having a prolonged period of chronic illness and disability. But you will still die and you will still grow old. There's also the exceptional elder narrative, which talks about people who are exceptional, who are by definition different from all of us. So we look at this and we think, maybe you're a guy, you look at that, you think your abs didn't look like that at 18 or 28. I look at this woman doing the splits and I think, ooh, I'm going to need orthopedic surgery. And then there is the silver tsunami, which is very witty. Like I can see why it's catchy, and yet it is so harmful. So the old people are made into a monolithic, colorless gray mass of people, and they are coming for the younger people. This is pitting generation against generation, when in fact we know child health helps older people, older people's health helps children. A society that cares for both these groups is a far more successful and healthy society than one that doesn't. And it sort of gives society a pass on all the ways in which ageism creates the problems it then complains about. In medicine, we often see this where older people aren't included in trials. And then when the outcome is poor, they blame old age. In society, we see it where older people can't get hired or are forced to retire and then blamed for not working and contributing to the economy. There are all kinds of funny books about this. These slides are terrible. I apologize. I'm not sure what happened there. Age doesn't matter unless you're a cheese. I hope I have already shown you that age does matter. And the more we own our age and rejoice in it and show how it's so varied like any other age, the more our world will see old age and create systems for older people in all their variety. This is a little cut off, but it's old age is always 15 years older than I am. I think many people, maybe most people, feel this way. I find among my patients and even myself that we're all a little shocked when this happens to us. It seemed like one of those things that happens to other people. And then just sort of playing to the stereotypes of crotchety old men and little old ladies. I think the crotchety is worse. Maybe he's crotchety because he's being treated so badly, and that she's little is inevitable. We all get smaller as we age. Nothing wrong with being small. This is from Boston's anti-ageism project, which I don't agree with. So this is this gorgeous woman, age 86, who says she's many things, but over the hill isn't one of them. So for those of you who are scientists, if you look at a bell-shaped curve, she is over the hill, right? She's past the halfway point by a long shot. If you're more narratively inclined, we think of the arc of a story, and again, she's over the midpoint. Yes, they're trying to show that not everybody that's over the hill is out of it, but that does two things that I think are harmful. One, it creates a world unfriendly to people who are less functional, are more ill, are truly ancient, and that doesn't do anybody any good. And secondly, it kind of disadvantages all of us who are over the hill, depending on your race and geographic location. Most Americans live sometime into their early to late 70s, some people much longer on average. That means some of us are over the hill at age 35, some of the more lucky at age 40, 45, maybe even 50 or older. In any case, this woman is decades over the hill, and wouldn't it be better to have a society in which it was great to be over the hill, in which we recognize just how much of life and pleasure and meaning and contributions and essential needs happen when we are over the hill. Speaking of which, this is another one of their images. This guy says he's many things, but frail isn't one of them. Again, creating a society in which when he is frail, and to look at him, he's on his way already. When he is frail, he's now helped create a world in which he will become a second-class citizen. By definition, I would rather live in a society where we recognize that we all have periods throughout our lives, from the moment of birth, and for the first many years particularly, and at the end particularly, but frequently in between, where we need the help of others, where we are not at our peak. And wouldn't it be great to have a society that welcomed all of us and cared for all of us with equal enthusiasm and respect? This is the poster for my institution. Actually, it's on the wall of the geriatrics clinic where I went with my mother last week. So we welcome all races, religions, countries of origin, sexual orientations, genders, ethnicities, and abilities, but all ages We do not stand with you. I tend to joke that at least they're honest. Uh, so turning a little bit, and I realize this is medically focused, but this is my world. And for each of the things I talk about, imagine it into your world or your community or your household, maybe even. Medical education for doctors, training is 4 years long. We get about 2 to 3 months training on children who are 23% of the US population currently. We get 2 to 3 weeks on older adults who are 17% of the population, but 40% of hospital discharges and 30 to 70% of clinic visits, depending on which medical or surgical specialty you're talking about. So the representation in medical education is neither proportional to demography nor proportional to health system usage. This is blatant discrimination. In public health, I showed you those CDC curves showing that with each decade of old age, the risk for COVID and the outcomes got worse. And yet, this is their 2021 vaccine schedule. On the left is for children. You are not meant to read this. I'm sorry, it's so hard to read. It's just sort of to show you that along the top horizontal axis are ages. We decide who gets vaccinated based on the strength of their immune system, which relates to age in part. Obviously, people can have immune diseases as well. So strength of the immune system, social behaviors, and general biology. So for kids who change markedly in their first 18 years, there are 17 subschedules. For adults between the ages of 19 and 64, there are 3 subschedules. There used to be 4. And then for people over age 65, yes, for that half century, there is a single schedule, as if we all couldn't tell from a block away that a 65-year-old is different from an 85-year-old is different from a 105-year-old. Again, structural, blatant, shameless discrimination. In medical research, we learned something a while back. In the early heyday of 20th century medicine and research, that which gave us our longevity, so I'm not devaluing it by any means. What they did is they basically studied healthy, white, mostly heterosexual, or at least as far as they knew, men between the ages of, say, 20 and 50, sometimes 20 and 60. They did this because they said, well, women have those funny hormones and other people just aren't like us, right? Because who was doing the work? And they had all kinds of incredible inventions. But what they found pretty consistently was that when they excluded all these other people, children, old people, women, people of color, because they were different, and then applied the trial results to them, they actually got different results because their initial assumption that these people were different was often true. Now, it wasn't always a biological difference. Sometimes it was a social difference, an access to care difference, a dietary difference, but they were different. So in the 1980s, the National Institutes of Health mandated the inclusion of women and minorities in research. In the 1990s, they mandated the inclusion of children in research on products that would be given to children. When did they mandate the inclusion of the highest age group user of medical care in medical research? 2019, folks, 2019. So, ageism. In healthcare, we also see this. There is a very important and successful motion to make health systems age-friendly. That is to get more and more people thinking about what matters to an older person, and that does differ for people, even for the same individual. If you think you have 20 more years or 70 more years versus if you have 2 more years or 2 more months, what matters to you and what matters to you at this phase of life? Medications, because they do so much harm to older people and so much good. Mentation, because we all like our brains to work, and mobility, because we all like to be able to move around. So it has really made a difference in getting people to think about this, but you can get certified as an age-friendly health system where one small part of your health system is thinking about these things. Whereas what do children get? Children get entire hospitals full of specialists and subspecialists. The ART budget for our relatively new children's hospital, larger than the whole elder care budget. So blatant, shameless ageism everywhere. This again from the Ontario Human Rights Commission. From a human rights perspective, there's a lack of a sense of moral opprobrium linked to age discrimination, which in comparable circumstances would generate outrage if the ground of discrimination were, say, race, sex, or disability. Even pets actually do better. Like if you think of pet abuse versus elder abuse, I kid you not, you cannot make this stuff up. And this matters in part because internalized ageism kills. This is tremendous work from a woman named researcher, psychologist at Yale called Becca Levy. Tons of different work in this area, looking at the fact that people who have more positive attitudes about old age have their first cardiovascular event, heart attack or stroke, 7.5 years later. She's shown this in all sorts of areas, recovery from hospitalization, Alzheimer's markers, all sorts of things. The mechanism is thought to be twofold. One is that when you have internalized discrimination of any kind, internalized homophobia, internalized racism, that elevates your levels of stress hormones. That leads to inflammation, which leads to accelerated aging. The second is more positive. If you believe that your life phase has meaning, that you have meaning, you're more likely to eat well, to exercise regularly, to keep up your social connections, to do all those things that we know help people stay healthy. So yes, you can recover better, you can live longer, but more importantly, I think, since we live so long now, you can live better, but not in an ageist society. And the society is so ageist that you may not have heard some of the ways in which older people have thrived in the pandemic. This is not everyone, but on average, older people have done better. A psychologist wrote in my favorite medical journal, the New York Times, that people over age 50 generally, based on tons of stories, have more positive emotions and fewer negative emotions, independent of income or education. This does not include truly impoverished rural and immigrant communities, none of which have been studied adequately. But we've seen this in pandemic, how, yes, people who are institutionalized and put in solitary confinement for a year and a half have not done well. People with underlying depression have not done well, but many others have done quite well in COVID, better than a lot of the kids, the teens, the people in their 20s. So finally, to wrap us up, I'm going to talk about some steps we can all take to improve elderhood now and for future generations. There is a tech will save us approach, and tech's coming whether you like it or not. So I think the more associations of retired people can work with Silicon Valley to develop tech that's actually useful and doesn't just tell your adult children whether you've gotten out of bed, whether your heart rate's going up. I mean, they all assume nobody old has sex or nobody old wants to have a lie-in because they were out at seeing the new James Bond movie till midnight or any of the normal things people do. They make all kinds of assumptions. So the more they meet real old people, the better. There are some pretty great things in Japan. Some people think it's a shame, but these animals bring pleasure. And I think if you have advanced dementia to the point where you're not recognizing anybody and something makes you happy and gives your life pleasure, I'm all for that. There's ways of remote monitoring, as you saw in the first thing. There are things like things that will help caregivers, particularly if you're a small female caregiver of an older, a large male partner or anybody else that's small caring for somebody big. If we had machines that could do the literal heavy lifting, that would be great, although it'd be better still to have machines that would enable the frail or disabled person to care for themselves. And then are there scary things? Yes. This is a fake nurse. She's a bot. She's a robot. Yeah. So there's that. I'm not sure I'm for that. Anyway, this is going to happen, like it or not. The more we participate, the more useful it will be. The science will save us approach is actually pretty interesting. There is an emerging field called geroscience. Some of the stuff in the anti-aging sphere is also geroscience. I strongly encourage people to use the word geroscience, not anti-aging. Usually we're like anti-racism, we're not, we're against the ism. So it would be better to have anti-ageism, not anti-aging. So this really works on how can we improve especially the health span, maybe the lifespan, and it takes a really different approach instead of the one disease at a time approach, which actually causes big harms in older people. Because if you follow the guidance for each of the many diseases we all accrue as we get older, you end up with a very busy schedule of taking medicines, doing activities. It's one that sort of precludes a normal life. So what we would do better with was something earlier. And my colleague, who's a basic scientist, said that some of these molecules would make a bigger difference for the human population than if we cured heart disease, cancer, and dementia altogether. There are all kinds of innovations in diets. These two primates are the same age, but you can see how the one on the left has aged and the one on the right has not. This is partly due to a low-calorie diet, which led to a longer health span, but interestingly, not a longer lifespan. But wait, there are all these molecules, many of them are in trials. The trials tend to show that where the natural course is the black line, so you have a bunch of years below the level of disability and dependence. The intervention moves you to the red line where you have much more time in health, in ability, and independence, and a much shorter period of time with disability and dependence. We all want that. Well, it turns out we're spending billions, maybe trillions on this science, but there's something that already does this and treats at least 15 major diseases, delaying dementia, treating cancers, heart disease, depression, insomnia, anxiety, diabetes, hypertension, and that is called exercise. But do we give people gym memberships or access to exercise? Do we train physical therapists to optimize people's physical function rather than just teaching them to use an assistive device? Not so much. The World Health Organization has a kind of nice paradigm for how to move forward. It says healthy aging is being able to do the things we value for as long as possible. And they have 4 different areas that we will briefly cover. Developing systems for long-term care. COVID has really shown everything that's been known for decades. I have a nursing colleague, Charlene Harrington, whose research on this from the 70s forward proves everything that COVID has shown, if anybody had listened. We saw how it started in nursing homes, how most deaths were in nursing homes. And most recently, a group at Harvard looked at and found at least 16,000 uncounted deaths and 68,000 cases among nursing home residents. So that this needs to happen can't be questioned. Fortunately, we learned in COVID that smaller places, fewer than 50 beds, had hardly any COVID. These greenhouse type places also tend to have happier staff that stays longer, is paid better, and happier people who live there. They actually get to eat dinner when they want to eat dinner, not at 5:30, and other little sort of treating people like a human being inventions that don't happen in standard nursing homes. The VA system has pledged to this. The state of California is thinking about it. Aligning health systems to the needs of older people. I think you've seen the ways this needs to happen. We need to stop talking about just kids and adults. And in fact, we need to talk more about kids. And we shouldn't have the exact same rotations that doctors have to go through that my father did in the 50s or I did in the early 90s. The world has changed significantly since then. We now all learn to deliver babies. About 3% of us will ever do that again after medical school, whereas about 85% of us will take care of older people, and there's no training requirement. I showed you the vaccine schedule. I mean, CDC just needs to be consistent. It knows what it knows. It saw this with COVID. I really hope that next year they have a vaccine schedule which shows respect for older people and the subsegments of old age. In medicine generally, you can fill in the blank with almost everything, and the better outcomes will be in people in their 60s, the worse outcomes on average, people in their 80s. That is important for both groups because maybe the people in their 60s aren't at such high risk and would benefit from certain treatments that might be harmful, might actually be the ones killing the people in their 80s. Until we break down studies and really look at people by decade or by health or functional status, we will not know what the best care is for older people in the same way we do know for younger people. Healthy aging is an area that my group of geriatricians has not focused on. We have always made the argument that there's so few of us that we're going to focus on the oldest and frailest, which actually keeps us small, because if you think of if all pediatricians just dealt with adolescents or just dealt with neonates, there would be far fewer pediatricians. We really need to deal with all the subgroups of old age, because while it's wonderful to get great care when you're very old and frail, it's even more wonderful to have a clinician who will help you delay your frailty and thrive in your old age. And we know a bunch of ways of doing that. We just need to convince people that the time to do it is now. We need to create age-friendly environments. This is true on big and small scales. Age-friendly communities are an international movement. Think of how you can apply this to your communities, your academic communities, the communities in which you live. This could be transformational, and it's just every time they talk about kids and adults, you bring up elders. In each of these sectors, I would actually split some of them. I feel like civic participation and employment are completely different, for example, but I'm always a splitter. There are little things like getting your home ready. The number one reason older people are sent to a nursing home after a hospital stay is not a medical need. It's a functional mismatch between their recovering selves and their home, because people tend not to redo their homes until there's a crisis, and then often they get moved somewhere else. So if you want to age in place, change your home and do it now. There's a great organization in San Francisco called At Home with Growing Older that can help you do this. It's got a website. So changing door handles to ones that can easily be used. And in COVID, these were great. You could use your elbow, making bathrooms safe. This no longer has to be ugly. For a long time, everything for older people was ugly. Baby boomers are not having any of that. Parks have places for kids and adults to play. Some of them, mostly in wealthier areas, are getting places for older adults to work and work out, to keep them healthy, to socialize, to safely exercise. But we don't have anywhere near of this, and we need to get this into all communities, because the lower income communities are the ones that need it most. The age discrimination in employment is appalling, ubiquitous. The laws actually begin at age 40. So if you're in your 60s, good luck with that. It was the reason why so many people in their 70s were turning to entrepreneurship prior to the pandemic. This is a major battle that needs to be fought. Using technology, getting public spaces to be places where we can hear things. In San Francisco, in the dot-com boom, they intentionally made restaurants louder. We need to not go anyway and yell at each other, but preferentially go to those places that respect our ability to hear each other and not wanting to text at the table, as many people do. Finally, we need to change in the way we think about aging and older people. When you look at the human lifespan, when you Google it, you often get a chart like this: 4 categories for children, 4 for adults, and then a single view of old age with people in a wheelchair. I would argue in my later 50s, I'm in the penultimate or second to last category. My mother, 30 years my senior, now 88 years old, is not in a wheelchair. So how do we create a language for these intermediate groups? How do we create a world that sees older people in all their diversity and respects them and values them in that same diversity, that understands that for younger people, the old people are their future selves, that there are generational differences and there are age differences, and sometimes these are different. For instance, right now, if you think about technology, the problem isn't age, it's that you cannot be a digital native and be an older person. This is going to change. Just as, the great and silent generations didn't ask for what they needed in healthcare, the boomers do. There are cultural and generational changes that should not be conflated with old age itself. This is Ursula K. Le Guin. Some of you no doubt recognize her. In her later work, she wrote about her own aging into her 80s and had a couple quotes that I love, which is: to tell me my old age doesn't exist is to tell me I don't exist. She owned it. She was it. She was incredible. She also made this joke that I love: if I'm 90 and believe I'm 45, I'm headed for a very bad time trying to get out of the bathtub. This is from San Francisco's anti-ageism campaign. You can see the current ages of the people on their eyes and their younger selves above and below. And it's just to remind us that in every adult is an elder in training, and in every elder is an adult who matters. So I leave you with a final thought. What if the greatest limitations of aging come from our imaginations and policies, not our physiology? And I don't by this mean to devalue physiology or the diseases and struggles that come with age. Those are real, but they are made worse in so many ways. And with that, I will stop and thank you for your attention.
Thank you so much, Louise. That was really incredible, so comprehensive. So I have a bunch of questions for you in the chat.
Okay.
So I'm just going to go through them. The first one is, what do you say to someone when they say you look good for your age? Is it okay? Is that okay to say to someone that you're trying to compliment?
Ooh, it's such a good question because, we know we look different. But I guess the question is, why do you need the qualifier? So some people argue, just say, hey, you look great. Because that's really the part that matters. Chances are, if you're adding the qualifier for your age, they probably already know they're not 18 anymore. So you're providing unnecessary, sort of information. And you're also kind of complimenting and insulting in the same thing. And if what you mean to do is compliment the person, just say, wow, you look terrific. How are things going, or whatever else? I think that's probably sufficient.
Right. It's sort of like saying you look great for a woman, right? Or you look great for a man.
Right.
Why would we do that? Right. Okay. So
you throw pretty well for a woman.
Right, exactly. Okay, so the next question is, are there funding mechanisms in place that encourage medical students to focus on the aging process and serving the elderly? Helping to defray medical school costs might be a way to encourage new doctors to select geriatrics as a specialty. What are your thoughts on that?
That is a great question. There really aren't. There's the occasional single scholarship at a couple of places, but nothing uniform. There is some precedent there with loan forgiveness for people who, then go into the military or work in the Indian Health Service or work in the public health service with various populations. There is not something similar for aging. People have studied this to try and figure out, how much of this is funding, because my former division chief used to say geriatrics is the only subspecialty of internal medicine whereby learning more and getting additional training and skills, you can be paid less. I think actually rheumatologists have the same problem. Which may be because there's so much arthritis in women as we grow older and autoimmune disease in women, you've got to wonder. Interesting ways of intersectionality. So it seems part of it is also the ageism, the sense like, what can we do? Which is actually self-perpetuating, because there's actually a ton we can do. But if you don't actually teach it to people, then they feel incompetent. And a lot of us go into medicine because we like that sense of competence, like you're here for help and I'm going to help you. And that feels awesome to me. So then they get these negative impressions of old people because they don't know how to take care of them. And then they take bad care of them because they're feeling negative about it and they don't realize there's stuff to learn, and on it goes. But part of it probably is income. So if you want to, fund like students to do this, or have funds for partial debt repayment, and that could be at the residency level. So there is this other interesting phenomenon where some people come in interested in older people, and sometimes it is trained out of them. As they acculturate to medicine, they are less likely to be inclined to want to take care of older people. Part of that is medicine's focus on little organs or diseases, that kind of thing. Part of it is the devaluation of older people and geriatrics within medicine. And nobody wants to be on the losing team necessarily. but we're working on that. I actually think we're doing better as there is more about aging in the general area. And one of the heartening things we saw in pandemic was how many young people volunteered to help, and really they were still othering older people, like, oh, we can help them because they're so old and they're so high risk and they're so needy, and that part kind of is cringeworthy. But they really mean well, and we could work with that far more effectively than we have. And if you all want to, establish funds to really encourage this and to support increased training, either at the medical student level or when people are doing residencies, that would be huge. If anybody has a particular specialty in mind, there's also increasing focus, like there are surgeons who now focus on old people. There are cardiologists who focus on old people. Some of them do dual training. Some of them just develop the interest, but we're starting to see this across specialties in ways that are pretty exciting. So happy to discuss that with anyone at any moment.
Great. Yeah, great. That's wonderful. And just to tag on, do you know what percentage of newly trained doctors select geriatrics as a specialty?
Oh, way less than 1%. I mean, way less. We don't fill all our fellowship slots. You get a certain number of foreign medical graduates afterwards, and we have we don't have very many graduate training slots, and they don't fill. In places like San Francisco, where we don't have a huge training program, and we're in San Francisco, we fill, but most programs do not.
Right. Yeah. Okay, so we have another question about what retirement organizations can do to combat ageism and support healthy aging. And just as an intro to this, I'd just like to mention that we at NYU have adopted something called the Wrinkle Project, which is basically a way to combat ageism and age stereotypes at NYU throughout the university. And we have wrinkle salons, we're doing a desk cafe, we have lectures on ageism in the workplace, ageism in the family, and so on. So I'm wondering what your thoughts are about sort of what retirement organizations can do.
I love that. The wrinkle. Oh my gosh. Okay, it would definitely get everybody's attention. I love it. So what can retirement organizations do? Well, one thing they could do would be to accept age. I don't know about you, but a lot of them send me pictures of people who are better looking in their 60s and early 70s than I was, whenever you think the prettiest time in life was. So I'm not going to get, I'm pretty sure that isn't my future. Let's put it that way. And yet we don't really see a lot of the truly older people. So I think you want to show, it's like any form of diversity. If the organization itself is denying the hardest parts, we're never going to have other people comfortable with it. It's sort of like there are lots of studies in medicine that if you don't use what we call the D word, death, with a patient or a family, they don't know that they're dying. They just think you're telling them they're really sick. And so we have to use the age word, and we have to claim it for ourselves. I'm still in my late 50s, but when students are in their early 20s, they truly can't tell the difference between me and official, like, American old age. So I just start using old, and they'll sometimes say things like, "Oh, you're not old," and I'll say, "Well, I actually am old, and I'm great. There's not a problem with that." And you just kind of normalize it. As you can see, I grew out my hair, not for everyone. I actually just last week was talking to a patient that she should dye her hair again because it's just messing with her head, because we do live in an ageist society. But the more we can claim it and own it in all its diversity and in all its subsegments, including in organizations, to talk about the hard stuff as well as the good stuff, that will matter. To help people get employment, to really advertise the better things about the comfort with self, the ability to better prioritize, all those things that come with age that are the good parts that really don't get enough PR. I think another thing aging organizations can work on is terminology, right? I mean, we know the terminology for adults isn't great, but we sort of know there's like younger adult, middle-aged. That kind of works. But what do we have? We have like old, young, oldest old. There are jokes about it. We just don't have language that's accepted. And if we could come up with something that most people agreed upon and use it, and if we could use the terms that already exist, like old, elder, elderly, senior, and just own them with pride, I think that would go a huge way towards increasing visibility and influence.
Right. Yes, I agree. So I had one other question that I would love to ask about around owning age and adding age to the sort of DEI suite. Which, you mentioned that when you took your mother to the doctor, there was that, that beautiful list of, we care about and we accept everyone but old people. So,
except my mother.
Right. And all of us one day, right?
Right, exactly.
And my question is, what do you think about, like, how do we get age into that, sort of DEI area? How do we get everyone to care about ageism in addition to all of the other isms?
Well, one of the things I'm trying to do is to point out the synergies, or sort of the nefarious synergies, of ageism and racism, because there's so much attention on race right now.
Yeah.
So specifically talking to the harms done to older people of color, because that is where the topic is. And, people make a good counter argument, which is that a lot of Black and brown people don't get to be very old in this country. And so to push up older white people when other people aren't getting a chance is a pretty hard sell, and rightly so. At the same time, it's, again, not a zero-sum game. So I think we need to include ageism in the conversation. We might, as a nation, have some other priorities that need to come first at times, and I'm fully on board with that. I agree that people need the same fair shake from the beginning, and we can add ageism. One of the things I like to do is draw parallels. So, here's what we did for disability. Here's what we do for kids. Here's what we do for people of color. Here's what we do for LGBTQ. Now, here's what we do for old people. Does anyone else see a problem?
Right. Sort of adding the standpoint theory, aging standpoint theory, right? Right. So another person asks about language that older people use themselves that reinforce ageist thinking and behaviors, even among, so she wrote, even among those of us who are older and like to think we're opposed to ageism in all its forms. It's insidious, when people say something like, over the hill, or when they buy their friends, birthday cards that make fun of how old they are. There are all these ways in which we reinforce those stereotypes, right? So what do you think about that? Because I actually think that this is maybe sort of like the nut to crack.
Yeah.
Like our own internalized ageism and the implicit ageism that we don't even realize.
Right. Well, and I think there's also a fine line, and maybe people draw the line or the blurred boundary in different places between having a sense of humor about the realities of who you are and ageism. Right? Because sometimes things are funny. There are things we do that are funny,
right,
because of who we are. And it's a truism, even if it's maybe also a stereotype. So I think being comfortable with the language, if you look up the words for older people, all of them simply mean a person who's lived longer. So you take that language back, right. Kind of like, Black is beautiful, we're here, we're queer. I think those analogies really hold. Like, I'm old, or now I'm elderly, or I'm a senior, or just being able to say that and not think of it as an insult, not having people lower their voice, but sort of like, this is what that looks like. Or actually, this is one of the ways that looks. Right. Because what happens is people aren't considered old until they're kind of disabled or very old. And that makes old age a small category. Whereas the reality of old age, we all know, anybody who's made it to middle age knows that stuff starts happening, right? And that things change. So it makes old age seem smaller and less important. The bigger we make it, the more analogous to adulthood and childhood, the more it will be seen and recognized in all its diversity. So owning those words, using those words, and recognizing your own ageism. Part of why I wrote Elderhood in my 50s was that I started making those cracks myself, about myself, with my, little students who are 22. You guys teach people even younger, some of you. But they all look young. They all look like they're 12. They all have perfect skin, like all these things. They all can run way faster than I can now, and then I realized, like, on the one hand, don't beat yourself up, because it just means you're a well-acculturated person. And on the other hand, try and correct yourself. The first thing I did was, when I'd say something bad, I'd add something good. And now I try not to say the negative things. And if I do, then I just kind of acknowledge it. It's like, oh, I might have just had an ageist moment, to model the fact that we all do it, and that it's okay to acknowledge it and stuff like that. So there are many different approaches you can take to that. And then I'd love us to work on the language so we can feel happy with it.
Right, exactly. Okay, here's another question. My doctor of 40 years retired. I can't get used to a new younger doctor. Should I seek a geriatrician as my family doctor?
Oof. Well, I would say yes, absolutely, if you can find one. I mean, literally every day of my career, I've just received a message. We can't get anyone in San Francisco. It will probably be well into next year. There's been no availability this entire year of 2021 in San Francisco. Yeah, well, I mean, even getting a primary care appointment is tough right now here. So it's really hard. Lots of places have none. What I would say is start asking your insurer and your health system about it. Why do they have people specialized in the care of kids and adults, but not someone specialized in the care of you? The more noise we can make, the more action we can take. This is what gets responses, right? They're not going to listen to somebody like me, but if the consumer, as we now call patients, if the consumer is up in arms, they may well listen. And there is good data that you get different and more age-specific care. I think in an ideal world, we'd all have a pediatrician, then an internist, then a geriatrician, or a family doc skilled in whichever areas of life you happen to be in. And similarly for nurse practitioners and physician assistants. So that would be my ideal, because we actually don't get any training. Actually, we don't get much training in adulthood. We just did here the what they call life cycle, which is basically from fertilization. There's more time spent on the embryo than on adulthood. Let me put it that way. And I actually said to my small group after we had finished, I said, I just want to be clear with you guys that we're talking about the oldest and frailest here, and focusing exclusively on them is kind of like if in pediatrics you only focused on neonates. And they burst out laughing because the pediatrics time was so short, they'd almost exclusively learned about neonates. So that's insane.
Right.
Yeah. So ideally, yes. I wish that for you. And if not, if there's somebody who can see you as a consultant, and work on healthy aging or something like that simultaneous with your internist or family doc, terrific.
Okay, great. Here's another question. We hear of other countries, cultures that actually honor the aged among them and translate that attitude into behavior, including care. I'm wondering if people of different cultural backgrounds in this country value the elders among them differently.
Yes. So certain people from certain backgrounds are more likely to keep their older relative at home. It varies a lot, and economics really play in this country too, because if you're very poor, depending on which state you live in, like if you live in California, you're very poor, you can get care at home and you can get care in an institution, but that is not true in all states. If you're very rich, anywhere you can do anything. So I always tell my students, like, there's no age at which it isn't better to be rich. But then if you're in the middle, so for some cultures, it is a matter of pride to continue to take care of your older adult at home. So immigrants often more likely to step up and continue providing that care. People from certain backgrounds more likely. People often ask me about, like South Korea and Japan. In a recent study of ageism across countries, they actually looked almost as bad as the United States. We have exported that to them. Yeah. So that is no longer a model that holds. But yeah, they're definitely older people are valued. They're not always valued in the optimal way. It's more like a filial, responsibility. And part of that is really good. When I say to people, like, let your kids help, you took care of them, their rebuttal to me, and I think this has weight, is I chose to have the kids. They didn't choose to have to take care of me. So I can kind of see that. And at the same time, if family, and some families, obviously grievous harm has been done to people. So when I give this in certain audiences, people are like, you can't tell me I have to take care of the person who did horrors to me. I'm not saying that. I'm saying that if you have a family where no harm has been done to people, then I don't think it's an unreasonable expectation that we care for people at whatever stage when they have needs. And if we could embrace that as a larger social value, I think that would go a long way towards helping old age.
For having those conversations in families, right?
Mm-hmm.
I mean, that's the right thing for families to actually talk about what they want long before they need it.
Exactly.
Right.
And some people will say, well, we try to discuss this with our kids, and they say, no, that's depressing. Don't discuss it. So what I advise then is saying, like, hey, what are the grandkids talking about? Well, they're talking about school because that's where they go. What are the kids or adults talking about? They're talking about work and dealing with the kids. So you say to them, hey, so this is our stage appropriate conversation.
Right.
Yeah, we're going to tell you about the cool, movie we went to see, or the trip we went on, or what we're doing, but we also need to discuss this because it's a fact of life and it's very appropriate to our stage. And I'm sorry if it makes you uncomfortable, but I'm also seeing this as part of my parenting, because if you can be comfortable with it for me and your father, your mother, your whatever, then it's going to be that much easier when your time comes. I think this is going to be good for us. I'm not saying it's going to be easy, but we need to do it.
Right. We're being role models for you.
Exactly.
Yeah. Okay. So
I hate to interrupt, but we're going to have to end the session in just a few minutes in order to get people a break.
Okay, great. So I guess that was the last.
Yeah, the chat disappeared. There was one question I saw briefly, which was, what's my MFA in? And it's in writing, not surprisingly, perhaps. So fiction writing.
Okay, great. So Louise, thank you so much for this wonderful presentation, and your Q&A was fabulous. I am so pleased that I've, sort of been able to be part of it with you. And one question, the last question is, are you able to share your able and willing to share your slides? No pressure.
Yeah, I can. I've got a PDF I can send there. Because of the photos, it gets really hard to send. Like UCSF just blocks me basically. But I can send the PDF version. Okay,
that's great. Thank you very much.
Thank you, and thank you for that introduction, which was incredible. I still want that bit of I do this like this, and that was like, wow.
I'll send it to you. I'm glad you liked it. I'll send it to you. Okay, thanks everyone.
All right.
Enjoy the rest of the conference.